Consumer Reports poll that cost is a huge thing. I think if there's one takeaway point from this as providers, even as families, is cost really factors into whether a patient takes their medications. I had a patient, BH, who just came in, dialysis player, cardiac patient, stroke, everything. She had everything. And we're like, okay, let's go through your medications, doing that nice med rec. She's on all these medications. We're like, are you taking them? She's like, I'm taking them. I was like, really? Okay. So we were like, all right, well, where do you get your prescriptions refilled? I was because we're going to call it in for you. And she's like, okay. We called the pharmacy, and they were like, oh, she hasn't picked up any prescriptions in the last 6 months. And I'm like, what? What? So we go back to her. We're like, you haven't picked up prescriptions in the last 6 months. What happened? And she's like, oh. Then she came clean, and she said, well, they cost about $200. And I was like, that can't be right, because I'm looking at these medications, and most of them are generic. And I was like, what out of this is costing you $200? So it turns out atorvastatin was still, even though it's generic, is still costly. It was actually $50 a month. And I was like, and I was like, and then the calcium acetate, she's a dialysis patient, is a binder. That was $120, a month. And so I ran to her nephrologist. I was like, you got to do something. Like, what? And then, he's like, oh, she doesn't need it. I was like, what? I was like, did you tell her that? He's like, did we not tell her that? I'm like, oh my God. So she, because it was $200 picking up all these prescriptions, and actually one she didn't even need, the high cost one, she just was like, well, I'm not going to pick up anything, So we got rid of the calcium acetate, the atorvastatin, and there's other statins that are much cheaper on the market. It was like, you just need to be on a statin. I don't care if it's atorvastatin. You just need to be on a statin. That are $4, like pravastatin, simvastatin, and all of a sudden we're like, your bill is $25. Can you manage that? And she was like, yeah, I can do that. I was like, done. And it was like, but it's those kind of things, like cost is just such a big thing that we don't ask about. Okay. And the generic medications, this is more of an older generation issue with physicians than a younger one. The younger ones, I think, came up with Walmart and Target, the $4 prescription plan. So they're much more used to, like, oh, generics are fine. The older generation, and I still see this. I'll walk into a patient's house, and I'm looking at their medication. I'm like, what is this? What is this? And I have to look it up on my Hippocrates. I'm like, what is that? It's a new thing that just came out, and that's the thing. There's constantly new medications getting pumped out. And we're getting detailed about, and they say, oh, this is better. We have studies that show it's better. So doctors are like, well, why wouldn't I give my patient the better drug? Because it's newer, more snazzy, whatever, has a nice catchy name to it. Problem is that higher copayments, for sure, higher copayments. And that is going to be a real distraction for patients to pick up that medication. All right, so we're going to talk about some ways to kind of modify these risk factors. So one thing is to do, and there's a lot of, Sutter Health actually does out in California, does a lot of work around motivational interviewing. And it's basically what you want to do is you want to collaborate between, the provider and the client. You really want to kind of ask them, what are the barriers that are preventing you from being adherent? And you're not coming from a place of judgment, but more a place of empathy. Like, what is it about? Oh, that diabetes, that is hard to control, Not be like, well, you should have just controlled it, but like, yeah, that is hard. What can we do to help you with that? And you want to actually really evoke and draw out their ideas about change. What do you think would benefit you if you did become adherent? What would happen? How do you think how we can bring about that change? And you really want to try to self-empower that patient. So one of the questions I like to do if I really feel like I'm like not moving the needle on this person is basically, let's just pretend if you were able to make the changes that we'd like you to make, what would be different about your life? One of the other things I also really try to do is try to ask for something they really want to do in life, right? It could be something as simple as, do you want, like, I had a patient who was like, she was falling a lot, and she was just, falling a lot. And her blood pressure was a little bit labile. And I was like, what is it that you really want to do in the next like 3 to 6 months? And she was like, I really want to walk down my granddaughter's aisle when she gets married. They said I could do it, and I really want to do that. And so that's all we did. For the next 6 months, I tried to, work with her blood pressure medication. She did a whole heck of a lot of physical therapy, like a lot of physical therapy, and just so she can walk down the aisle. But she was able to buy into the plan, mainly because she knew there was a goal. There was a goal. So one of the things to really kind of think about is like, what is your goal? Controlling diabetes, it's not really a goal. I mean, that's our goal, but it's not really her goal, right? So be like, what is it that you want to do in life? She's like, oh, I really want to take that trip. It's like, okay, well, how do we get you so you can take that trip? We got to get you feeling better, right? So how do we get you feeling better? Well, we kind of have to do X, X, and X. So let's do that, because I want you to get in a car and go on that trip. So kind of putting it more reality-based for them and not so much about what we want for them. Teach back, again, banners everywhere, right? So I think for a lot of providers, you guys know what the teach back method is. Very, very helpful, because we're spewing out like a ton of information out to them. You should do it like a timeout after you spew like all this information, this great, awesome information you're giving. You're like, what did I just say? Can you tell me what I just said? And patients sometimes are like stunned. I don't know if you get that response. They're like, oh, I'm supposed to participate in this? I'm like, yes. So and they're like, you said I should take this medication once a day? I'm like, twice a day? And they're like, twice a day? And then you realize where the knowledge gap is, right? This is, again, not a judgment thing. It's actually trying to have you kind of assess how much of the information they really received well. Okay, so teach back, I think, is incredibly powerful in the sense that you're giving information and then stop, and be like, can you just tell me what I just said? Okay, and then really assess if they got it. Just so you know, people tend to remember what is at the beginning of your spewing, of your litany of stuff, and what is at the end. Okay, so emphasize the beginning part a lot and emphasize the back part a lot. So usually what I do a lot of repetition, right? So I basically will say, I want you to take this blood pressure medication. I was like, because it's good for you, blah, blah, blah. I want you to take this medication. Okay, so really, pin it with the most important points in the beginning and the end. Be very specific of what you want to happen. Take this once a day. If you don't feel well, call me back in 3 days. Don't do the call me back later, because what's later, Or call me back once the antibiotics finish if you're not feeling well. So people understand, like, okay, I do a certain task and then I should see a result. If I don't see the result, then call me. And then really try not to overwhelm patients. Don't give them 5, 6, 7 things to do. 2 to 3 new concepts is enough. All right. Pictographs, I love. I actually have done more and more pictographs the longer I've done medicine, just because a picture really, it's like 1,000 words. I'll tell you, like, I'm like talking, and I'm like, you know what? Let me just show you what's happening with you. And the great thing is, like, Google Images, like, has like pictures, like 1,000 pictures of everything is awesome. So, a stroke, you can be like, well, this is what happened in your brain. And patients are like, oh, that's horrible. I'm like, it is, but then you're like, it is, it's horrible. So that's why you're like, you can't move your right side, So then they're like, oh, I get it. I'm like, good, other things, like, again, another picture of a stroke, but drinking, like fluids, is like, you got to limit it to 2 liters. How often do we tell that to patients with congestive heart failure? Like, can't drink no more than 2 liters. And they're like, what's 2 liters? I'm like, okay, that like Coke bottle, that you can get to get, I'm like, that's it. And they're like, oh, all right. And that can sometimes give them an idea. Or like, picture like this, 4 glasses of water a day. But, I do this, like, I in my sessions now, I have like Google up at the same time, because there's just so much more you can do with pictures where patients really get, like, if you're talking about like back pain, patients are like, or like spinal stenosis. It's like, it's one of those things, like, I'm like, well, you have arthritis in your back. It's kind of compressing your nerve. I mean, I can tell them what's going on, but it's so much better when I show them a picture with spinal stenosis, because then they're like, oh, that's horrible. I'm like, yeah, that's why you're in a lot of pain, and they're like, yeah. And I'm like, okay, so let's talk about what we're going to do next. And the buy-in is just so much quicker. So I tell people, and actually my nurse was great. She just went out and saw a patient of mine, and she was like, oh, I showed a picture of this, I showed her a picture of that, and she totally got it. I'm like, oh yeah, that's probably a better idea to do with that patient. So other behavioral interventions, I'm sure you've heard of health coach, telephone calls. I mean, Christiana has very much heavily invested in telephone calls. We have a whole big care link system now with all these nurse case managers calling patients to try to really impact their behavior. Postcards. I love MediPlanners. I just think it's a really great idea for patients to organize their pill planners. That way they don't forget what they're taking every day. Home blood pressure monitoring, I love it because, patients really need a cause and effect. So if I take this pill, is there an effect? Blood pressure is one of those great ones that if you take a pill, your blood pressure should go down if it's working. So then I'm like, you monitor that, get one, and look at it. Some people go a little bit bananas, I have patients who are like monitored 20 times a day. I'm like, what else are you doing? I was like, no. I only want 2 readings a day. And then my patients were trying to outsmart me. They will like do it. They would only show me readings before they took the medications. I'm like, no. They're like, I want you to see what it is natural. I was like, I know what it is natural. It's high. I was like, I want to see it with the medication. They're like, oh, with the medication. I'm like, right. So sometimes you have to be, again, concrete and specific about how to do monitoring. Copayments, again, I just want to talk to you. Just can't emphasize enough about cost, that insurance is vitally important for patients to be adherent to medications. So people without insurance are not going to be adherent to medications. They just don't have the money to pay for this stuff. If you're homeless, what's more important, a roof over your head or medications? It's a no-brainer. It'd be a roof over your heads. What's more important, food or meds? Food. So we have patients coming in and who really have very limited resources. The first thing to get is like, yeah, they got admitted for stroke and they need medications. But if you don't help them in getting insurance, at least medical insurance, you're not going to move the needle, right? So it's very important for them to get insurance. And once you get insurance, copays are very important. The higher the copay, the less adherent people become with their medications. So I love home delivery, being in the home visit realm. There's a lot of patients who can't get out to get their medications. There's a lot of pharmacies now that deliver home meds. I think we know every single one of them because so many of our patients are homebound and they have no one delivering medications to them. So it's so common for our patient to get discharged home. And, we now go out within 48 hours to see them. But before we didn't have, weren't so diligent about getting out there as quickly. So we might wait 5 days and we would show up 5 days later and patients like, yeah, haven't taken that medication. I'm like, why not? And it's because they don't have family, they don't have friends, and they can't drive, and they can't get out, or they didn't feel well. I said, I don't feel well to go and get it. I'm like, oh God, and they're right back in the hospital. So home delivery is fantastic, and there's, a good half a dozen pharmacies that all deliver medications. And, we, for the most part, do e-prescribing, which is great, instead of giving people handwritten prescriptions where they just stuff in their purse and then forget about it. Side effects of medications, people really are like, oh, I'm going to get a side effect. And I'm like, I really try to minimize that, to have them buy into it, that yes, you might have a side effect, but the vast majority of patients will not, I also try to tell them that, if there's something kind of side effect, sedation is a big one. If they're get sedated, I'm like, take it at night. I say, it'll help you sleep. You say you just told me you couldn't sleep well. Well, take it at night. I'll help you sleep. And they're like, oh, that's such a good idea. I'm like, yeah. Okay, reduce. So I'm big fan of de-prescribing. Okay, reduce the number of medications. How I do it is I take their diagnosis list and then I take their medication list and I try to match it up. Okay, if they have a diagnosis but they don't have a medication, I question the diagnosis, quite honestly. That is pretty much not that serious, that maybe I could take it off. The other way is more the fact that usually there's a medication and there's no diagnosis, right? And I'm like, okay, why are you taking this medication? And they're like, I'll tell you, most patients don't know what each medication's for, okay? So they'll be like, I don't know. I'm like, well, this medication is usually used for heartburn. Do you have heartburn? And they're like, no. I'm like, okay. Guess what? And I was like, I'm going to just take that from you, and they're like, okay. And I always tell people, it's like, it's not like a done deal. Like once you stop a medication, you can never go back to it, right? This is not like you only get one shot of this medication. If you burn through it, you can never go back on it. I was like, look, if we take the omeprazole away, the Prilosec away, and you actually do have heartburn, well, then we just add it right back. That's okay. Like that's allowed, And patients are like, oh, okay then. All right, let's do that. I'm like, yeah. So it's like, it's not that hard to stop medications. I just think no one has even mentioned it to patients to stop. Stop medication is a big, big thing. A lot, up to 25% of drug use in seniors is actually unnecessary, inappropriate. It's a huge amount. All right. Reduce the dosing regimen. Just think about yourself. Are you more likely to take 4 times a day medication or 1 time a day medication? Once, right? Same thing with our elderly people. Anyone that doesn't, me. I remember someone putting me on antibiotic once, and they're like 3 times a day. I'm like, are you kidding? I said to the doctor, I was like, no. I know there's there's ones that are twice a day or once a day. I'm on those, And she was like, all right, fine. I was like, great. I'm now labeled as a difficult patient. I was like, and take it during daily activity. So take it during breakfast, take it during lunch, put it with a daily activity. Communication tips, again, I'm very blunt. I've been, I think, burned so many times about the cost issue that I just flat out just ask patients now, like, are you having problems, paying for your medications? I just put it out there. That way they're like, oh, yes. I mean, just why beat around the bush? I just want to know, are you having trouble, paying for these? Because you are, I need to help you with this, like, right now. I love this cartoon just because I wish hugs were so powerful. They could take away prescriptions. And I think my patients will also love 8 hugs more than 8 pills. All right. So in conclusion, there's so many barriers to adherence. You need a variety of interventions. There's no one thing that works with, every patient is very different on what works for them. I have some patients that do beautifully with pill planners, and then some of my patients are a complete disaster with pill. I don't know why, but I was like, this is so easy, just follow it. And they just don't like it. They don't like that, rigidity. They're like, I like opening it myself. I'm like, oh, okay. It's a little bit of a disaster when you do that. And they put it all in this one big white bag and they just fish it out. I'm like, how do you know you just took it, And somehow they, I honestly don't know. They worry me. And I really try to get them to a pill planner. So there's a lot of different things, and everyone's different, and they're motivated differently. And you just, as providers, we have to be flexible, and not really toss up our hands when, like, they're not getting it. Something's not clicking, and you just got to keep going back and trying different ways.